Can we do better? Welcome everyone to our zSleepClub webinar special event. AHI and CPAP have been disappointments. Can we do better? With Dr. John Remmers. Very exciting evening. I'd like to start off by always acknowledging our many sponsors that help so much, not only in helping us spread the word about dental sleep medicine, but also with the various products and technologies that they develop and bring to the table to help us keep up in the game and doing a better job for our patients. So thank you. And also a little reminder for our zSleepClub members, we're on holiday, it's the summertime, but our next session, the start of the season, is September 19th, where Natalie Morin is going to be talking to us about the new and improved Knox T3, including their new software and some exciting developments there. So a little reminder, you'll be getting a join link. Little housekeeping, select your computer or phone audio and follow instructions, and then there's the questions. The questions will go in this section here on your little panel, and you can minimize your screen by that little panel by clicking on that little arrow on top. Make sure that it's not in your way and covering up the slides. And at the end of the webinar, there's some questions that you have to fill out if you'd like a CE certificate, which you'll get within a week. And if you need AGD points, this qualifies for AGD, but you have to include that information in that little questionnaire. So just make sure to take a moment to fill that out. Now, Dr. John Remmers. This man impresses me so much, and I'm a huge fan. I mean, he's been around since the very beginning, basically the first person to elaborate, elucidate, explain what is happening with obstructive sleep apnea in the medical literature. He's published over 100 peer-reviewed papers. He's been editor-in-chief of medical journals. He's being involved in and invented many devices like a home sleep screener. They've been involved in auto PAP development. Also been involved in diagnostic type of tools to help us, demonstrate that an appliance will work for a patient and what the optimum position is in the way of the matrix, that original one that was used in the sleep labs, and then put it in our hands as dentists with the Matrix Plus. He's been a huge proponent of oral appliances over the years, and as far as I'm concerned, played an instrumental role in helping to keep the AADSM online and on track and evidence-based, because he was always there calling people out at the microphones over the years when they were just talking hogwash up at the podium. So I thank him for all that guidance, and I really don't think the ADSM would be what it is today without John's participation over those years. And I think they could continue using his help currently because of getting a little bit off track there. But anyway, hopefully with people like Fernanda and John and the wings, they can get the ADSM and keep it on track and evidence-based, because it's an important organization to this whole cause. So here's some of the devices that John's been responsible and developing and bringing to us and helping us. And thanks so much, John, for all your contributions. And without further ado, what I'm going to do is make you the presenter. And you can, once that happens, you can call up your slides and start your presentation. Thank you so much.
Hit show my screen. Shall I bring up mine now?
Yeah, bring up your slides.
And I'll make a slide view here.
And the rest of us can grade
How's
our
that?
camera. Yes, you're up, John. That's great.
You can hear me. So good evening, everyone. A pleasure to be here. John, thank you for your efforts and all you've done. So know that there's a reciprocal feeling. And I can just summarize my life for the past 20 years has really been about providing an alternative to CPAP for treatment of sleep apnea. Just an alternative. We want something like that. So I am ready to tell you that I have a conflict of interest. I'm the chief scientist or medical director, things like that, of Prosomnus Sleep Technologies. I will show you some data that I gathered, but it was before I joined Prosomnus Sleep Technologies. But I have a big conflict of interest, and you should know that. But it won't be apparent in most of what I say. It won't be involved in most of what I say. Here's where we are. We're in chaos. Apnea-hypopnea index is of uncertain clinical utility. Continuous positive airway therapy is no evidence that it improves long-term outcome. So we have standard medical therapy, and we have no evidence that it produces improves long-term clinical outcomes, even though it's been around for 40 years. I'm going to begin by saying, look, this is so screwed up that I'm going to ask, is OSA really a disease? So, and the purpose of the presentation is to review the reasons for the chaos and suggest there may be a light at the end of the tunnel. You know this, but I'm going to say it anyway. Sleep disorders is a major public health epidemic. That says the CDC. And if you use AHI 5 as your definition of sleep apnea, you have a billion people around the world that may have sleep apnea, and most of them are undiagnosed and untreated. Here's the important one. Bill DeMett, he's the father of sleep, not sleep apnea or anything. The father of sleep died recently. And he said sleep apnea remains the most undiagnosed deadly problem in medicine. Okay, well, let's dissect that, what Bill said. He's a very careful man. First of all, it's in medicine. So he says this is a medical disease. I completely agree. It is a medical problem. I completely agree. He didn't say disease. He said problem. Oh, that's interesting. And then he says it's deadly. Well, we're going to review that tonight. But undiagnosed, that's correct. So whether it's a deadly problem or not is something we're going to be actively looking at tonight. So is it really a disease, OSA? A disease is any harmful deviation from normal function associated with characteristic signs and symptoms. Okay, I think we can agree on that. And there may not be a sharp demarcation between disease and health. In our area, snoring may not be a disease. Upper airway resistance, who knows? And OSA, we're going to ask, is that a disease? So sleep apnea, is sleep apnea a deviation from normal? No doubt. When we're asleep, we're supposed to breathe, breath after breath after breath. That's called pulmonary ventilation. We have an interruption in pulmonary ventilation. That's not normal. So we can say sleep apnea, by definition, by what the word means, is a deviation from normal. The question is it harmful? That's the central question. We cannot consider obstructive sleep apnea a disease if it isn't harmful. Half of people with sleep apnea are asymptomatic. They may not be sleepy. And we've known that since the very early days of the Wisconsin sleep cohort. And what about comorbid illnesses? There are a lot of those. So what's going on here? Is it harmful or not? Well, we have comorbid illnesses, and here they are. You know them: depression, stroke, heart failure, obesity, hypertension, coronary artery disease, AFib, type 2 diabetes. With all of that, I mean, how can it not be comorbid illnesses? How can we not have a disease here? Well, don't forget, association does not mean causality. So it doesn't mean that sleep apnea is causing those harmful things. They both can be the result of some third factor. So we haven't proven that OSA is harmful by just saying it's got a lot of bad associates. It runs with a bad group. No. What about mortality? Even more compelling. Don't go to sleep, said Mark Twain. So many people die there. Well, does sleep apnea kill people? The answer is maybe. Is it associated? Maybe. So it depends on really how you measure the severity of sleep apnea. So what you're asking really is, in severe patients, do they die with OSA? Do they die prematurely? Well, that raises the question of what do we mean by severe? right now, traditionally, we've used the apnea-hypopnea index as our surrogate index. By that, we simply mean it's the index that tells you whether or not the disease is present and how bad it is, how severe it is. And we've used AHI from the beginning, from the very beginning, 40 years. And we're not sure that it's a good index. Here's what makes us think that sleep apnea is associated with premature death. This is the Wisconsin sleep cohort at time 0. Polysomnograms were done on 1,500 patients, randomly selected. And then again at 6 years, and out here at 18 years, 12 years, and 18 years. And we get this kind of time frame. And of course, this is a cohort. We're just observing them. We're not treating them at all. We're saying, what happens to these 1,500 people? We know which ones have sleep apnea and which ones don't. So up here at the top, AHI less than 5 by the gospel, that's no sleep apnea. And down here at the bottom, AHI greater than 30, severe sleep apnea by the gospel. Big difference, it looks like. Excess mortality of 30, 40% due to sleep or associated with sleep apnea. So that's an association, but we've had trouble replicating it. So we did another study following the Wisconsin sleep cohort. We did the Heart, Lung, and Blood Institute, and that was another cohort study, larger number, 6,000, a little bit older, and severe sleep apnea predicted or was associated with mortality in men 40 to 65 years. Full stop. You may not have heard that before, but that's what the data shows. So if you take all comers, everybody that it was in the sleep heart health study, and ask, is severe sleep apnea associated with mortality? The answer would be, we really can't show it in that cohort. And then there have been other studies that have failed to demonstrate a significant relationship between sleep apnea and mortality. All right, well, here we go. We're not sure about whether it's causing death, whether it's even associated with death, but certainly we don't have any causal relationship. The first thing to ask is, are we using the right surrogate index? Is this AHI the right thing? Well, what's it telling us? AHI tells us a lot of things. It tells us that there's a problem with anatomy, something causing the ventilation to stop and start again. And then we know that loop gain and other, quotes, endotype factors, they're neural factors, play a role in when you have apneas and hypopneas and cause more apneas and hypopneas. So we have anatomic factors, but we have these endotypes, they're called. So AHI is telling us, the endotypes are there and the pharyngeal anatomy is bad. That's good. But it doesn't tell us how bad an apnea is. It tells us nothing about the depth and duration of apnea-induced oxyhemoglobin desaturation. Now, that's a mouthful that I just said there, but that's the key thing. It tells us nothing about the depth and duration of apnea-induced oxyhemoglobin desaturation. Is hypoxia important, you ask? Well, I can tell you, as a pulmonologist, been around a bit in intensive care and stuff, hypoxia, not apnea, kills people. So you can stop breathing for 10 seconds and you're not going to have any hypoxia. But desaturation and resaturation, down and up with the saturation, that seems to be particularly harmful for the arteries, for the coronary endothelium. So these are findings based in research. That's not my ideas. There's research to indicate that. Okay, so we say, well, hypoxia is probably not a good thing. Would an index reflective of the depth and duration of apnea-induced desaturations be a better predictor of mortality associated with OSA? Would it be better? And I happen to say, yeah, I think it would be. Just telling me that the guy stopped breathing, that there was an interruption in pulmonary ventilation, doesn't tell me nearly as much as a physician as the oxygen went down. And how far did it go down, and how long did it stay down? Those are things that I would ask. So we need something that's the equivalent of blood pressure for hypertension or glucose for diabetes. In other words, these are the harmful factors. I mean, if you you have a stroke, you've blown out your cerebral arteries because the pressure is high inside. So there's an equivalence between the harmful effect and the index. So we need an index of the harmful agent that reflects the risk of mortality. That's what I think. And not sure that AHI does it. So which is better, AHI or something I'll call hypoxic burden? Which index better predicts risk of death? We'll ask. So you know what the hypopnea index is: no breathing for 10 seconds or 30% reduction in airflow followed by desaturation. But look, we can have these are transient events. They are completely arbitrarily invented again 30 years ago by a committee that I chaired, but Christian Guilleminault was the big pusher there, and we call it Christian's great mistake because it became the foundational index of the field, but we're having trouble showing it that it's important. I mean, is it important that you stop breathing for 10 seconds? I can tell you, people who have normal lungs don't have a desaturation when they stop breathing for 10 seconds, maybe not even 30 seconds. So the breathing is not the place to look, I would say, from my perspective. I say apnea hypopnea predicts nothing except reimbursement. So it doesn't predict all the other things we would like to have predicted. It just doesn't. Sorry. I went the wrong way there. Excuse me. So what about oxygen? So I would say rather than some arbitrary definition of an event, and then we're going to count up the events and divide by the number of hours of sleep. That's the apnea hypopnea index. Why not quantitate something that's a continuous variable and is important, like O2 saturation? So we're not going to arbitrarily say, here's an event. We're not doing that because you made it up. You just say, oh, well, I think this would be a good definition for an event. So we're not doing that. We're going to say, let's look at the oxygen saturation and let's look at the saturation that's caused by the apnea. We can do that. I'll show you we can do that. So we're going to say we have other metrics that we use, time less than 90%, but I'm not going to go there. I'm going to go at the hypoxic burden. It quantitates the drop in O2 saturation caused by sleep apnea, not something caused by cardiopulmonary disease, emphysema, COPD, none of that, just related to sleep apnea. So we want to know how much hypoxia was caused by sleep apnea. And we're not defining events. We're not having any new definition of oxyhemoglobin desaturation, anything like that. That is what it is. That's classical physiology. So hypoxic burden is an index that may predict the harmful effects of hypoxia resulting from OSA. And I'm going to tell you now about the predictive power of what we've come to call the hypoxic burden. It's been evaluated by 2 large cohort studies. So it's not my research, folks. I'm telling you what's out there, but I can tell you that it's being well recognized. And if you attended the 2022 sleep meeting, the keynote speaker would be lady shown right here, Susan Redline out of Harvard. She's the leading epidemiologist in the field. And the keynote speech, she talked about things like hypoxic burden. So this isn't to be ignored or to thought lightly of. And you want to stick with AHI and stuff. No. Forget that. But here we go. In the European Society of Cardiology, European Heart Journal, we have this publication, and the world's greats are on there, by the way, Wellmans and Whites and all these people. So this is good stuff. And as I said, it undertakes an evaluation of the hypoxic burden in 2 separate cohorts. And by cohort, I mean something like the Sleep Heart Health Study. And so you go online and you can find the data from the Sleep Heart Health Study, the baseline data, and then you can find out when the person died. And so you can ask a question like, is the AHI or the hypoxic burden related to survival, chance of survival? And there was another study done on elderly folks who had orthopedic problems, had fractures. And again, it's more like 3,000 people, but big studies, polysomnographically based. Good stuff. Okay. Here's the hypoxic burden. First, let's start at the top. Here's breathing. In, out, in, out. This is airflow. And then the airflow stops. Here, so I've told the guy this was working better, but it's not. The airflow stops, and it's stopped, apnea, and then it starts again. So what we want to look at is the desaturation that occurs during the apnea. Okay, during the shaded area here at top, there's a desaturation that's associated with that. It's caused by it. I mean, that stop in breathing, that caused this drop in oxygen. And it's delayed by circulation time. So here's when you stop breathing, and here's where the oxygen starts going down. You know all about that. The oxygen goes down progressively, hits a minimum. Then when you start breathing again, after a circulation time, it comes back up to normal. This is what we're interested in. This is the hypoxic challenge caused by the apnea, and that's exactly what we want to know. So we're going to look at the area here, the shaded, dark area, and add them all up and divide by the number of hours, and we'll have what the drop in oxygen caused by sleep apnea was. It's not related to AHI. Here I want to show you hypoxic burden on the y-axis and AHI on the x-axis in one of the two studies. And you can see there's a lot of scatter here. So we wouldn't want to say that AHI, hypoxic burden, would be the same in most people. They might reflect the similar things in some people, but sometimes you can have people with a low AHI and a big hypoxic burden, and vice versa, people with a low hypoxic burden and a big AHI. So it's a new variable, and that's kind of what we want. We need to look at a new variable and see if it does a better job of predicting risk. We're talking about it right now, the risk of dying. There are other risks, cardiovascular diseases and so on. But right now we're going to talk about the risk of dying. Here's it is. This is for the sleep heart health study, I believe. No, this is the orthopedic study. It's the same for the sleep heart health study. It's a cohort study again. At 0, they did the polysomnogram, and periodically they did another polysomnogram. And they mainly, you don't treat the person, you don't do anything to the person, you just watch when people die after the polysomnogram. How long do they live? What's the chance of survival? And then you plot that against the hypoxic, the survival chance here, the probability of surviving at various levels of hypoxic burden. Let's look at the three up here, the orange, green, and tan. They're low hypoxic burden, okay? So you have a survival curve for them. You got about 20% of them dying here in 15 years. But if we look at the magenta, the bottom one here, and the blue one, those are more severe hypoxic burden, and they're associated with a lower chance of survival out here at 15 years. So these are severe hypoxic burden, big hypoxic burden. And these up here are mild hypoxic burden. Pretty nice. I mean, you could say it was the same as what you saw back there for AHI, but as you're going to see, not really. This is better. Here's the conclusion. Unlike AHI, don't miss that first. Those three words right up there. Unlike the AHI, the hypoxic burden strongly predicted cardiovascular disease mortality and all-cause mortality. Whoa. So AHI didn't cut it, but hypoxic burden not only cut it, it strongly predicted. These are the world's best epidemiologists. Nobody's questioned that. That's what the data showed in both studies. So 2 large cohorts, and that's what the world's best epidemiologists are telling us. So I say this suggests, but does not prove that OSA has harmful effects. Could be. We have a reason to postulate that it does, right? But causality, though, cannot be established by these cohort studies. They can't show. They can only be causality can only be shown by an intervention. We're going to intervene and say, let's get rid of it, Mr. Jones, Mr. Smith, and all the patients that have severe sleep apnea. Let's say, let's get rid of the sleep apnea and see if they live longer than a group than if we didn't get rid of sleep apnea. So it's randomized controlled study. That's the basic fundamental way we learn things in this world, is a randomized controlled study. And we're going to have to do that to find out if sleep apnea kills people. We have reason to believe that it does here, and that it's a useful index would be possibly the hypoxic burden. Seems to be better than the AHI for sure, but still we can't say that we're home free. And can say sleep apnea is a disease, because we have to do that. We have to show that it causes harmful effect. Okay, and so that's what we're going to do. We're going to do the randomized controlled trial. What I'm going to show you is called the SAVE study, randomized controlled trial, taking people with moderate and severe OSA, as judged by the AHI, unfortunately, and we're going to randomize them into usual treatment, that means no treatment, or CPAP. You know the study. There are other studies that are showing the same thing, but I'm going to show you the biggie, the SAVE trial. Again, published in a pretty good journal, New England Journal of Medicine. And you see, against people like Susan Redlab, David White, and all the greats are on this Doug McAvoy study. He's the principal investigator. So a lot of people, 2,700 people, and we do the randomized control trial, right? We put them randomly, put half of the 2,700 people on no treatment, just watch them, usual care, and the other half on CPAP, and watch them. Randomly selected, randomly assigned. No difference, no significant difference between in preventing cardiovascular events, comparing CPAP versus controls or no treatment. Okay, so let's look at just the insert here. On the y-axis is cumulative incidence of cardiovascular events. The event is a heart attack, a stroke, it's onset of AFib, etc. So we note them all down when they happen and add them all up, percent divided by the total number of people, and we have this is how many events occurred per 100 people, and this is time on the x-axis, 0 up to 84 months. So, I mean, this is great. A lot of people and a long time. So if there's something here, we ought to see it. If CPAP preventing heart attacks and strokes, we ought to see it. We don't see it. No difference. Now so we're trying to show here, remember, that sleep apnea causes heart disease, strokes, and heart attacks. And we try to get rid of the sleep apnea and show that you get rid of those events. And we didn't do it. Didn't work out. So we still can't say from this data that sleep apnea is harmful. Well, why not? We conclude that CPAP did not significantly reduce the occurrence of serious cardiovascular events. These are in non-sleepy people. That's what they did. They studied non-sleepy people with moderate to severe OSA. Why not? Well, you say, I know what you're going to say. Poor compliance. They only used it 3.3 hours per night on average. Well, that's in the treatment arm, okay? The other arm that we're comparing it to didn't use CPAP at all. But in the treatment arm, on average, 3.3 hours a night. In fact, if you think about that, that's about at the limit of acceptable limit for compliance. That's about it, the definition for a borderline between incompliance and compliance. So I think we should have seen some effect. So maybe compliance is not the full explanation. Maybe incompliance in the treatment group is not the full explanation. CPAP usage was low, but the results should have demonstrated some mitigation of cardiovascular events with the treatment. It didn't. Patients with AHI greater than 30 may not be the most susceptible to mortality effects of OSA. So that's what we have to say. Remember, the relationship between hypoxic burden and AHI is all over the map. And so maybe we should have selected patients for this trial. The ones that are most likely to die might be the ones with a high hypoxic burden. The ones that were down there on the magenta line that were going to die soon. So that's just an idea. It's a possibility. We use the wrong definition of severity. Remember, though, unlike AHI, hypoxic burden strongly predicts cardiovascular disease mortality and all-cause mortality. So if we went back or if we'd done it differently, we might have seen something if we were using hypoxic burden. We were using AHI to select our patients. You had to have an AHI greater than 30 to be severe and greater than 15 to be moderate. Okay. So, I'm sorry, getting close to winding down here. I'm going to ask, is OSA really a disease? Is obstructive sleep apnea really a disease? And that was where we started out. We wanted to find out about that. The answer is maybe. Maybe. Does it have harmful effects? Maybe. We haven't been able to prove it yet, but it may be. But I would say stay tuned. I think we're going to have studies that will elucidate that. But at the present time, we're still walking around scratching our head on this one. I'd like to turn to oral appliance therapy, not CPAP therapy. And I'm just going to add a bit here about where we are with oral appliance therapy and how that might influence where the field moves in the future. I'm going to tell you about our studies with Prosomnus appliances. We call it a precision appliance. The devices are milled accurately, fit well, prevent mouth opening during sleep and stuff like that. But anyway, these are the appliances I was using. But this was in my previous life at Zephyr, where we were making that product Matrix, and we were doing studies to evaluate the predictive accuracy of Matrix, but in the process, the predictive accuracy of predicting success or failure. So we had lots of patients whom we selected, who we included in the study, mild, moderates, and severes, and we gave them all oral appliances, and then we have outcomes. We adjusted the oral appliance as well as we could, and then we have note down what the AHI was in the patient with the oral appliance in the mouth. So the outcome is what's the AHI of the patient whom you're treating with sleep apnea. The results have been published recently in the Journal of Clinical Sleep Medicine. I had no conflict of interest when I did this study. I had nothing to do with Prosomnus, and I didn't necessarily think they were the best or the worst device. I really knew nothing about sleep appliances. This is studies done on the device that is the precursor of the current Prosomnus leading device, which is called Evo. This is a pre-Evo device. But the results are interesting, and I want to show them to you. First of all, the precision appliance and its efficacy. Efficacy means what's the percent of people who get an acceptable therapeutic response immediately, not a year down the road. It doesn't involve compliance or adherence. It just, if I put the device in the mouth, do I get a therapeutically successful result? And so that's what efficacy means in my use. And effectiveness is going to mean something different. It's longer term. It's going to involve compliance. But this is what efficacy means usually. So efficacy is what I'm plotting here, percentage of study people that had an efficacious response. And efficacy in the study was AHI less than 10. So with the oral appliance in the mouth, was the AHI less than 10? Well, look at this. Here's mild to moderate, which is what we're cleared by the FDA to use these devices for, 94%. If you round it off, it's actually 95%. So that's pretty high for by traditional standards. I mean, that's on par with CPAP. We're getting the CPAP range here. CPAP's going to be 100% efficacious when you use the CPAP. You get rid of all the apneas and hypopneas. You have certainly an AHI less than 10. Well, look at this. The mild and moderate patients had a 94% response rate. That is AHI less than 10. Ooh, that's pretty good. And if we included severes, we drop down here. So the efficacy rate is less in severe patients. It's around 70% in severe patients. And we had about one third, mild, moderate, and severe patients. If we include the severe patients, now we're down to about 81%. Still pretty good. Compared to the old days when we were intended to be in the 50 to 60% range, I'm patting myself on the back, thinking, well, we got a better treatment, and that's published data, and I had no conflict when I did the data. That's just what fell out. So that's encouraging. I want to say I'm looking for encouragement now, and that's encouraging to me. Here's some of the softer stuff, the patient report stuff. 85% reported achieving their treatment goals, whatever that was, whatever treatment goal they had, they achieved it. Here we have snoring reduction. You can see the people who, most of them jumped right down in their snoring. 97% reported reduction in snoring. 69% reported improved sleep quality. And 61% reported improved daytime energy. So we're getting some responses apparently. This is just one study. It's like 100 patients, and it's not to be overdone. But it's I think a quality appliance. My company makes it and makes a better one now. So it's a good appliance in my opinion, and it seems to have really nice effects. And we relate this to what we call precision appliances. I'm not sure. We don't know why this appliance maybe have a higher efficacy rate than another appliance, and that's not the point here. We haven't done head-to-head comparisons or anything like that. This is just saying, here's the results we got. It's an observational study. Here's the results we got for efficacy of sleep app of a precision oral appliance. I'm going to say now, ask you a question. Is oral appliance therapy, using the kind of appliance that I just showed you, is it as effective as CPAP? And I've changed the word. Now I'm using the word up here, effective. Effective is something, it means that we give the person the therapy and we tell them to use it, and then we follow up in some period of time. It might be a month or it might be a year, whatever we choose, and we say, what's the AHI and ODI, or maybe what's the hypoxic burden now? So effective includes not only efficacy, but adherence or compliance. All right. So I say, well, I'm very encouraged that oral appliance therapy is going to be as effective as CPAP. Why? Because we now have efficacy, which is comparable to CPAP. 94 versus 100. It's close enough. But we have adherence, which is much better with oral appliance therapy than with CPAP. So I'm going to tell you that I'll predict that I'm predicting that at least we're going to have comparable respiratory outcomes, comparable maybe AHI or comparable hypoxic burden. So I'm going to close with what I call Remmers musings. And first is, are the halcyon days of CPAP and AHI over? Possibly. I'd say possibly. Probably, I would actually say. So they've been the foundations of our field. Okay, AHI has been there from the beginning, and it's what everything is based on, and that's it. And I'm not saying we shouldn't use it. My point is not that we don't want any more AHI, but what it's describing doesn't seem to be related to adverse outcomes. And this CPAP, I mean, I love it. I invented two of them. The auto CPAP is my invention. Of course, I love it. It's wonderful, but it's clear that we can't show improvement in long-term clinical outcomes. We haven't been able to show them. They might exist. I'm not saying that there are no improvements, but we've done really pretty classy trials, and we haven't shown it. So I'm just stating the facts. So I think the halcyon days, the days where we just move ahead blithely with CPAP and AHI, they're coming to an end. There's been this scathing AHRQ report. That's a technology assessment agency in the United States. Their job is to tell us how good therapies are. And they noted that which is what I've told you, CPAP does not improve long-term clinical outcomes. They also noted that the evidence for AHI being a useful surrogate, a useful surrogate index, is weak, very weak. So a lot of my attitude that I'm telling you comes out of this report from the AHRQ, and really is, but it's a very seasoned, impartial, and thorough review of the literature, and so have a look at it if you like. It's available in draft form right now, but it's pretty scathing. So does CPAP reduce the hypoxic burden of OSA? Remember, we're not just saying hypoxic burden in general. We're saying the hypoxic burden, hypoxic challenge that's caused by each event, an apnea or hypopnea. And so I think CPAP will not consistently reduce the hypoxic burden. Why do I say that? Well, it's because most people don't use it for the full night. We're talking about a population. We're talking about an intent to treat trial. We're saying, I'm going to prescribe CPAP, and then I'm going to go down the look in a year and see if the hypoxic burden is down to some very low level. And I think half people might not be using it or using it only sparingly. The average usage from this SAFE trial would be about 3 hours a night. Well, the rest of the night, we have no treatment, and we have a high hypoxic burden in people who are moderate and severe. So I think we're going to have, if you look at the whole night, you would have to say the hypoxic burden is not pushed to a very low level by CPAP because of the poor long-term compliance. And then I also will note to you that usually when my thinking about the hypoxic burden in CPAP is that people rip off the mask halfway through the night, and in the early hours of the morning is when the REM is the most prominent. So we have a phase of sleep where the challenge caused to health and life caused by sleep apnea is the most prominent. So there's a lot to this. So might the precision oral appliances that I'm working with right now reduce the hypoxic burden? We don't know, but coming soon. We're going to do a historical analysis of the data on the patients that we studied without any bias, at Zephyr. We have that data still, historical data, and we're going to ask just that question: what happens to the hypoxic burden when we get successful or unsuccessful sleep treatment by the usual standards? And I think the oral appliance will have a strong effect on severe OSA if we're talking about its reduction in hypoxic burden. And we are carrying out as we speak, or starting next month actually, with Eddie Saul, Stanford Group, Harvard Group, Mount Sinai, and Minnesota, a 5-center study looking at, this is FDA level, all been approved by the FDA, looking at the safety and effectiveness of Evo, our oral appliance, in treating severe OSA. And we'll be looking at AHI as an outcome variable. We'll also be looking at hypoxic burden as an outcome variable. So that's going to be interesting, and we'll have some good information on that from really good investigators here in a matter of a year or so. Light at the end of the tunnel. Is it a locomotive or not? Well, maybe there's a good light at the end of the tunnel. There's a light there, but maybe it's the end of the tunnel. AHI will continue to define OSA, and it should. I mean, look, apnea is a cessation of breathing, so you can say that's how we're going to define OSA, but maybe not rank its severity, its risk of hurting you. Hypoxic burden and other indices. By the way, there's another index that's recently been looked at called the delta heart rate, and it's basically the same. You look at it when you have the depth of desaturation after an apnea. You look and see how much the heart rate went up, and that's predictive of mortality. So there are going to be new indices coming out that will may become preferred or more predictive for risk. And that's all I'm talking about. I want to know whether, and I'm worried about this because we can see that CPAP didn't do much to didn't at all reduce the risk of cardiovascular disease. So I predict that CPAP will no longer be standard medical therapy. That's what I've always written in various reports and things. We call it standard medical therapy. Well, should it be standard medical therapy? We haven't been able to show that it improves long-term outcomes. I mean, it's efficacious, but if you're treating somebody with TB, you got the drug and it might help them, but if they don't take the medicine, their TB will still go on and kill them. I'm not sure it should be called standard medical therapy anymore for treating OSA. And I say the oral appliances will assume a more important role. That's my prediction. Just my feeling. How about it's just my feeling? And I think increasingly, this is a whole new idea. It's a talk that you need to have Dr. Almeida give. But I think patient preference is going to play a more important role in therapeutic decision making. So we're going to come to more systematized methods for making therapeutic decisions in sleep apnea, whether we ought to go for an oral appliance or unilateral hypoglossal nerve stimulation or CPAP. And we're going to be making these decisions, patients together with physicians. But I'm just going to tell you that I think patient preference is going to gain in importance, and that will have a big effect on the field. And I think that's it. Thank you very much. You have down there my email. I'm not very good with the email, but I'll try to answer your emails. And certainly, if you give me a call, I'll answer. But I'll do my best to respond to your emails. And would love to chat with anybody who would like to chat about these things.
Fantastic. Thank you so much, Dr. Remmers. That was, I hope everybody on tonight realizes how special that was, hearing from the individual that first explained what obstructive sleep apnea is in the literature. invented so many devices, including AutoPAP, that has become a standard of care and considered gold standard, now saying, I don't know if this should be really the thing. Oral appliances, could be the thing. And this is so meaningful. And some of the information that you've covered tonight, I think, is very promising for oral appliance therapy. Just going back to, in the last few years, since 2013, when they started talking about the SARA index and mean disease alleviation and the similar outcomes between these two devices. However, CPAP or PAP always continue to remain as standard of care, gold standard therapy. Well, I think we've come to a time, especially with the HRQ report that you mentioned, that it's time to reconsider all of this stuff and the direction things are going in with the top people in the field talking about different indices that we should be looking at. This is all very exciting for oral appliance therapy and providing us with potentially easy to use tools that can be used to help calibrate appliances as well. So I think that there's just all sorts of things that could be very promising that will come out of this. I'm going to go to a few. First of all, there was a few questions asking me about recording. Yes, this will be recorded. I will be sending a recording link to everybody that registered. So even the people that didn't make it here tonight will get access to the recording link so that they can watch tonight's presentation. So I'm just going to go, so that's taken care of. And I'll read down the questions for you here that are posted, John, so that you can address. Why not just look at the oxygen saturation index with the AHI?
Look at them together, you mean?
Yeah. OBI and HI. So what does hypoxic burden bring to the table?
Yeah. So the key is that this whole idea of counting things up is flawed. It describes how many of these things happen, but we know how many of them happen depend upon your arousability, your loop gain, and things like this. So just counting up the occurrences and saying, here's how many occurrences you have per hour, is flawed fundamentally. That's Christian Gilman's great mistake. He loved it, by the way. He's a neurologist. And why did he like it? He thought every time you had an event, you'd have an arousal. It would disturb sleep every time you had an event. And so, whoa, I can see the patient in clinic now and see, oh, here the AHI is 50. You're going to be sleepy. Are you sleepy? And so they thought the predictive capability of number of events per hour would be great. Wrong. I mean, dead wrong. That doesn't work out. Christian and Christian's admitted that. He admits it was his great mistake. So that's the key problem that we must move beyond. And it's not a bad way to characterize the disease. Say, hell, I'm stopping breathing 100 times an hour. We see people like that all the time. And if you look at the desaturations associated with those events, it's 3-4%. It's some minimum amount of drop in oxygen. So the thought is that really that may or may not be related to symptoms. It's probably not, and it doesn't tell you anything. So it's something to do with drop in oxygen and bringing it back up again. This up and down in oxygen, that seems to be the key thing. Hypoxia alone, is not. I mean, you can live in Mexico City or La Paz and your oxygen, your O2 sat all night long might be 85, but but that's not the hypoxic burden. You understand? You can have COPD, and then you'll crash and burn and have big time desaturations in REM sleep. But they go down and stay down. It's a different thing. That's hypoxia, but we're talking about the hypoxia that's caused by sleep apnea. And it's a special kind of hypoxia. It's a dip, and oxygen goes down and comes back up. And it's quantitating that seems to be a pathway forward.
So, what are your thoughts or concerns on side effects of oral appliance therapy compared to CPAP? Is that just the side effect of treating patients? It is not, um, let's see, is that just the side effect of
Of
treated
course,
patients?
we have side effects. Okay,
Yeah,
look, it's not new in medicine for sure.
right.
We give drugs all the time that have side effects, and we warn the patient about them, and we watch them. But I mean, you hardly take a drug without being told that they're going to be possibly these side effects. They in and of themselves are not important. They have to be watched, and that's what we need you for, John, is to watch them, is to find out about them, to minimize them. We hope we have appliances that minimize them. So I'm not even thinking about side effects right now. I'm thinking about and patient acceptance is not a big deal, and preference. All of those things seem to be not front and center. But what's front and center is the lack of evidence that shows that oral appliances are as good as CPAP. I'll give you another example of where we're lacking over here with oral appliances. Uh, and I interviewed about 15 sleep physicians, leading sleep physicians. And first of all, I asked them, why don't people use oral appliances? Why don't you use oral appliances? And by and large, the first one was, it we don't think it works. I don't think it works, meaning it's poor efficacy. So poor efficacy in their mind was number one. And we're going to have to address that. And not just by one study, but by effectiveness studies that compare CPAP and oral appliances. That's a separate thing. But that was number one thing. They don't work. What's the second problem? Well, I lose control. I mean, not only am I sending them over to somebody I don't really know, and I'm not sure they know what they're doing, but I'm not managing the case anymore. See, I'm supposed to manage the case. It's my patient, and I want to manage that case. And what is key, a key feature in managing the patient is the feedback you get from CPAP. So not only do I know the CPAP is going to be efficacious, not only do I know it's going to be efficacious, but in addition, I'm going to see the patient in a year or 6 months, whenever I choose. And I'm going to have a look at how it's going. I'm going to see the compliance, of course, and it's going to be a problem in some people. And I'm going to see the pressures and the leaks, and I'm going to see whether there's a residual apnea, they call it. Does the patient have residual apnea? And that's what I do in the follow-up. And I'm still in control, is the point here. I'm the physician. I'm still in control of this case. And I don't want to give that up. So, it's not like saying, why don't you give this drug? And it's as good as CPAP. No. You're saying, why don't you put this thing in the mouth? And what I'm saying is the physician's going to resist losing control. So how are we going to keep them in control? We're going to give them feedback that's comparable to the airflow derived feedback that they get for CPAP. They get all these things that I mentioned, the apnea, hypopnea index, whether it's the central or obstructive apneas and snoring and IFL, they get all this kind of stuff back. How good it is, we don't know, but it keeps them, they feel in control. So you have to understand that we're not feeding that information back. We might do an occasional test, but we're not monitoring. Okay. And there's a whole move now as for remote patient monitoring. That's what you do in diabetes. So we're going to need to do remote patient monitoring. And that information can go to the dentist, but it needs to go back to the physician. So it's just like what happens when he has CPAP. It's the same. And so that's another fundamental difference and shortcoming. I'll put a fundamental shortcoming of oral appliances compared with CPAP.
Okay. When looking at the sleep study, do you count the lowest DSAT number, or do you take into consideration it may just have been for 1 second? So you look at the length of time at a specific low point.
Uh, the only thing that I know that has been tested systematically with regard to either death or cardiovascular event incidents is the time less than 90 and hypoxic burden. Nothing else has been done. So we haven't looked at that I know of, the minimum value. So it needs to be looked at, perhaps. We're going to be putting these together. So it may be that we'll have a role for minimum value. But right now, I don't have any.
John, let me ask you a question about that.
Clinically, but I don't look at it in a sense of knowing that it's a risk. Sorry, somebody is.
No, John, that was me. Sorry to interrupt. Let me ask a question about that, because my understanding that like the spot minimum value is most prone to being inaccurate. So what's more important is how much time they spend desaturated, how much time they spend below a certain saturation, whether it's going to be 88% or 90%, whatever you want to use. That's more critical than that minimum value. Just I'm looking to be corrected here. Like, what are your thoughts on that?
I would say we don't know. What I'm telling you is, I'm trying to be. I want to be fair and correct. And what I know is that it's this area. All that we know so far is that the area caused by the respiratory event, the desaturation area caused by the desaturation event. That's all we know. So, and what's important about that, we don't even know, because I'm telling you, there's a lot of pathophysiology that says it's the desaturation and resaturation that's important. Don't miss that. I'm not making any of that up. That's what the literature says. There's evidence for that. So we do have to explain why you don't have premature death if you move to Mexico City or La Paz. So it's complicated. Just stick with what we know, what the data we have. The data we have is that the area of this dip and rise back up, the area circumscribed by that right now seems to be important. But I think we're going to modify that, John. It's not going to, and it may be the depth is going to be more important, stuff like that. Right now, all we have is a hint that that there's something about that oxygen desaturation dip that's important.
Okay. Why not put everyone on with OSA on nasal oxygen at 4 liters per minute and eliminate the hypoxic burden? I haven't seen any evidence to see this as a treatment except for central sleep apnea.
We got to do the trial. I haven't done the trial yet. I'm not opposed to that. If you start talking about people with severe OSA, you might have a problem. You have to understand that what terminates the apnea and a substantial apnea is the drop in oxygen. So it's complicated to talk about what are you going to have when you put somebody on 100% oxygen. I mean, their oxygen will ultimately decrease, and that can be it will still happen. But I actually can't answer that question. The why not? I don't know why not. I really don't know. Central sleep apnea, we do have some understanding that first of all, it's treated by CPAP, and half of the population of central apneics, and that's because the lung volume is increased and it damps the loop gain. It shuts down the loop gain. But if that doesn't do it alone, then you can add oxygen and decrease the chemoreflex response of ventilation, and that will further eliminate central sleep apnea. But I don't know. I can't answer that question. Why not put somebody on oxygen? It's always been anathema to me. I always wanted to fix the apnea, but get rid of the sleep apnea. But who knows?
Both CPAP and oral appliance therapy attempt to overcome anatomic issues. I believe it has been shown that roughly 2/3 of patients have non-anatomic factors contributing to their OSA. Do you think that may explain some of the lack of effectiveness of these therapies in improvement in mortality? these non-anatomic factors may become worse in the aging population.
Right. That's a whole nother talk, but the answer is absolutely. So, but here I want to emphasize that we have an anatomic factor and we have neural factors, so-called endotypes. So you're right; it's the right way to describe it. We have both factors, and we want to get rid of the anatomic problem with CPAP. We just pressurize the airway with oral appliance. We protrude the mandible, but we have to understand that the AHI that we're trying to correct had a large component that was due to neural stuff, not the anatomic stuff. Okay? Now, with CPAP, you're shutting down the major neural factor, which is high loop gain. And people with sleep apnea, they're over responsive to a drop in oxygen. And that over response at the end of an apnea leads to a rise in saturation, which causes the next apnea. And so we get rid of that by pressurizing the patient, not usually talked about, but it decreases loop gain very much. That's intrinsic in CPAP. So we're treating the neural factor when we give CPAP. And in the extreme, that's the way we can treat central sleep apnea, but which is nothing but high loop gain. So, but here's a very important thing to think about. Oral appliances doesn't do that, folks. We don't change the lung volume at all. If you still have somebody with a big belly sleeping on their back, their lung volume is going to be low. That's part of what makes the loop gain high, and we're not going to change that. In fact, there are times when we actually increase the loop gain by our treatment. This is what I call a paradoxical response to mandibular protrusion. Sometimes when you're protruding the mandible, you begin from a retruded spot or a resting spot and pull it out. We did this a lot with the automated mechanisms. You can see that the AHI will decrease, and then you pull it out more, it'll increase again. And folks have all said, "Oh, well, that's some crazy reorientation of the size of the pharynx and stuff." No, I say. That's because you've increased the loop gain by by actually strengthening the contraction of the pharyngeal dilator muscles. As you protrude, you're stretching the dilator muscles. And any idea about that? Take the geniohyoid. As you protrude the mandible, the geniohyoid is going to get longer. A muscle that gets longer develops more force, and you'll have more dilator response at the end of the apnea. The long and short of it is, it's poorly understood, but probably a very important feature that we haven't recognized in the past, and I think accounts for some of the people who have who are found not to have an efficacious response to oral appliance therapy, to mandibular protrusion. It's not that we didn't overcome the anatomic problem. Maybe there is the accentuation of one of the neural factors. Long answer. I'm sorry about that.
No, it's good, John.
That's another talk, though, John. We'll give that one next fall.
This next question, I've never heard this question before. This is interesting. Has prosomnus ever looked at titrating an MAD laterally and placing pressure against the buccinator muscles in addition to vertical and AP titration? The buccinator is connected to the pteromandibular raphe and the tensions to the pathopharyngeal muscles and impacts the size and shape of the airway. So a 3D dimensional titration of the airway makes sense. CT imaging confirms increased patency.
Wow. No, we have not looked at anything like that. I would love to actually dialogue with this person about that. If we're going to talk about imaging, we're going to have to talk about imaging. What's the state of the patients when we're imaging it? You're imaging it awake. I'm not sure what it's got to do with what's going on during sleep. So I'll just throw that in there as a little caveat. But I'm look, I'm in favor of trying anything that might be make it work better. So I don't know anything about that Bostinator approach.
How is the hypoxic burden measured? Is it already in the sleep study?
No, this will be incorporated. You need to have airflow and O2 sat. So right now it can't be measured just with an oximeter. You have to have airflow. So you say, here's when the apnea or hypopnea occurred. Now here's the dip in oxygen that occurred because of that. So no, it's not widely available. Uh, we're working on it. Other people will be working on it. It'll come out. Your home sleep study will, in 2 years, have hypoxic burden jumping right out there. If I can guarantee you, something like the hypoxic burden and the delta heart rate. So again, you don't say heart rate variability. You can have a lot of stuff you can say about heart rate, but the study has been done. This cohort study looking at mortality, and again, Susan Redline was a big part of that study. That looks at the delta heart rate caused by the apnea. So when the oxygen saturation is peaking, desaturation is peaking. When it's going through its minimum, you look and see what the heart rate is there compared to baseline. So delta heart rate, apnea specific delta heart rate. That's what I want to say. Not variability. It's apnea specific or delta heart rate caused by the apnea. You look at that, looks pretty good. That's a very recent article in the Blue Journal, but recently been published. Great stuff, and recently been presented at keynote talks as well. So be on the lookout for that heart rate.
Why do we not look at end tidal CO2 as a marker?
Well, first of all, the CO2 doesn't rise much with an apnea. Why? Because the blood buffers the CO2. It stores the CO2. So when you stop breathing, you're no longer exhaling CO2 and you're no longer inhaling oxygen. For oxygen, the oxygen goes down progressively because there is no storage place for CO2, for oxygen, other that which is in the lung. And so, but for CO2, there's a whole other storage area, the blood itself. So you hold your breath, and you can hold your breath and have the oxygen go down to, if you could do it, 85% or 80%. And then you look at the CO2, the end tidal CO2 is the CO2 that reflects the carbon dioxide fractional concentration in the lungs. Look at that when you breathe out. It might be up 2 or 3 percentage points, or a few torr, not a lot. So that's just the way blood works. And that's why we normally, when we talk about the stimulus to breathe during these apneas, it's not that we don't think CO2 is important, but it doesn't change much. The pH doesn't change much during the apnea compared to what happens with oxygen. The oxygen will plummet right down because there's no other source of oxygen except that which is in the lung. So that's the reason we don't normally think much about the CO2.
So this is interesting. If hypoxic burden is so important, how do we explain Medicare carriers shifting from 3% to 4% AHI without any consideration for hypoxic burden? Hypoxic burden probably has not changed, even though the 4% AHI drops significantly. So I'm sure you have something to say about
Right.
that.
Well, this is going to be I've been around long enough to tell you that just because we have something that makes sense scientifically, it doesn't necessarily get through to Medicare for a while, or CMS. And so, yes, I'm not. My role in life is not to deal with those folks. I'm happy to say I just can't do it. My role in life is to do the science and talk about the science. So uh, I, I'm not the expert there, and I won't say much about it. But things move slowly for sure, and we generally you have to persuade the gods, the sleep gods. They're called. I call them the sleep gods. Those are the people who are write the guidelines for the AASM, American Academy of Sleep Medicine. The gods have to be persuaded, and you get the gods persuaded, they'll write new guidelines. like the stones coming down from the mountain, and the guidelines come down, and so now you got the word from Godberry, and then you can change it. You can do something about it.
Well,
So that's the first step. So what we want to change, we want to convince the world that you can treat all severe sleep apnea with oral appliances. Well, first thing we have to do this trial and go to the FDA and say, "Aha, here are you satisfied, FDA?" And they've told us what we got to accomplish to do that, and we'll do that. So we have to meet certain performance goals for the FDA. That's fine, and they'll say, "Okay, it's clear now for severe OSA." But that doesn't mean we're going to use it for severe OSA. We got to go talk to the gods, and that's probably going to take more than just our study. We're going to do 100 patients with the world's greatest investigators, but it's probably going to take more than that. The gods need more information before they're convinced about this, and then we'll finally convince the gods that severe OSA ought to be allowable to be treated by oral appliances, but then ultimately we're going to go head to head. We're going to have to show that we get better results with oral appliances than with CPAP.
here, here. Now, there's a question here about Pro Sleep coming up in San Francisco. John, are you going to be speaking at that conference?
I will. I'm not talking about this though. The world's expert, a world's expert, a dentist, uh, Dr. Radman, will be talking about hypoxic burden and delta heart rate. That's his topic. So we're bringing in an expert from Harvard, dentist that has worked on this. I'm going to be talking about, I don't know, it's the future and things like that. It's pretty weird, but I will be giving a talk, and I'm looking forward to having Barry come and listen to it. But it'll be a great. I think it's overall a really nice, very engaging, informative session, meeting. Trying to make it better. We want to be. Our brand is, evidence based sleep medicine, dental. I don't call it dental sleep medicine. I know we want to be a dental company, John. I want to be a respiratory company, and it's all based on, that's what we do. We're treating a breathing disease, and so I'm in favor of providing an alternative there, and so that's what we're going to be presenting ourselves as, for sure, and it's going to be based on evidence that we and others have gathered. But
John, we
coming
have
from
one
sleep, it's in late August, mid to late August, in San Francisco. We'd love to see everybody there for sure.
right, and anybody that wants information on it can reach out to Wendy Weishauser.
That's where you go. Go to Wendy. Go to that lady standing right over there.
And John, listen, could you just write off your email, because the individual with the CAT scan information wants to share it with you by email.
Yeah, it's jremmers at prosomnus.com. It's not hard. Real simple. And Wendy's is W. Weishauer at prosomnus.com. That's all we do. It's the first initial and the last name, prosomnus.com.
And I think you can all see the names on the screen there. All the attendees can see the names on Wendy's screen.
Yeah.
She can get that. Now, the pH logarithmic is as a small change is a red herring. The pH is logarithmic. I'm having trouble with that word. Logarithmic. And so a small change is a red herring with that pH change. That's just a comment that was thrown out here.
Please come talk to me. I love what you're talking about. More than anything else in this world, I'm a respiratory physiologist, and I know spend a lot of time working with blood and modeling blood and so on. So let's have a talk about that.
Yeah. A couple more questions, John. They're basically asking, are there any other indices? Now, you've mentioned heart rate variability, you've mentioned hypoxic burden. Are there any other indices that you want to mention or throw out there that might be possibilities for us to?
No, I'm sorry, I don't. There's none in this league that have been tested in cohorts of thousands. This is what we're talking about. We're confident here that we may be onto something just because the numbers are involved. And the delta heart rate was a different cohort plus the Heart, Lung, and Blood Institute cohort. So there are these cohorts that are there, and you can see them online if you want to go see them. They're the only two that I know of, John, right now. But I'm sure there are going to be other approaches, and we just have to. We're getting out from under the shackles of the AHI. That's all it is. AHI is still going to be there, still going to characterize the disease. It just says how many times you stop breathing or almost stop breathing. That's it. But it doesn't. We're looking for something much more important, and that's a problem with this disease. It's not that way with hypertension. The thing that defines the disease, increase in blood pressure in the systemic artery, also is the thing that blows out the artery in the brain and causes a stroke. It's not that simple for us. We have this way of showing how much the pulmonary ventilation has been interrupted, how often, and then we have the consequences of that in drop in oxygen, and it's the latter that seem to be important.
But the truth is, John, we still have an indirect relationship between hypertension and disease, and so that indirect relationship has been eliminated in essence by our AHI standards. So that's frustrating.
I'm not suggesting or predicting.
Oh, I know you're not.
I'm just saying it's going to go away.
That the recognition of patients' adaptive capacity and their endotype is critical, important, and critically important, and one of the major factors that we now recognize the AHI totally misses.
And if you as a dentist, when you're finished treating your patient, and you want to know whether you've done a good job or not, it's not going to be the AHI that tells you that.
Exactly.
It can still be 20, but
exactly.
You got the hypoxic burden down to very low. Slap yourself on the back. Say, I did a good job. So, I mean, that's what we're looking for. Not playing the stupid AHI game anymore.
Right, exactly. I mean, it's the amount of times that I was criticized because I wouldn't treat a 71-year-old lady with an AHI of 17 who had no comorbidities and was perfectly healthy. I mean, and we look back at the Levy studies and we recognize how irrelevant it was to treat her, and the abuse that I would take from my dental companions who would look at me as, "How could you're letting her stop breathing 17 times an hour?" No.
Yeah, no, it's very, very.
John, I have a comment. I really appreciated the comments on the SAVE study, because I can't tell you the amount of times that I've sat in an audience and listened to a dentist or a dental speaker talk about this, the fact that because the lack of effect of CPAP was absolutely looked at that 3.3 hours per night, and consequently it was therefore obviously compliance, and that with the assumption that an oral appliance would have been better because of the higher compliance based on the SAVE study, which is unbelievably frustrating. But the question I have is, do you know whether, if we look, obviously the biggest issue there is we've learned that endotype, that sleepy patient, really makes a big difference over who in the decision about who should be treated and what their adaptive capacities are. Has anything, does it make sense then we should be looking at sleepy patients versus non-sleepy patients and hypoxic burden?
Absolutely, it may be. So we're going to have and there's in this it's in the delta heart rate study that if you read that, Barry, in fact, their findings apply only in the sleepy patients.
Right.
And so you're absolutely right. We're going to end up with a prediction of risk that's going to include something like hypoxic burden, something like delta heart rate, but something like sleepiness and something like, I don't know, arousability or something else. And we're going to have them there. And we may not know how all of them work, but we're going to have them there because our data shows that each one of them may have some effect and be predictive. And then we're going to just have an artificial intelligence algorithm, the kind of thing we've used in our previous studies. And you just plug them all in, and it's going to tell you the risk. We have to have studies. We can start doing that with the existing cohorts. And so it's not necessarily, it doesn't make sense that one variable is a very complex disease with different factors that relate to different things. And so we're going to have to put, I think, this is just totally speculation over a beer, but I think we'll end up having a number of factors that will predict chance of survival.
The other thing, John, that I really appreciated was the discussion about disease and does apnea kill people. We understand, you and I both understand that we're now dealing with a second profession dealing with sleep apnea that was previously dealing with distal decay on a second molar, and consequently there's that tendency in dentistry to get a little dramatic, to use a little mama drama, and I want to save people's lives, and making not that we shouldn't be making the efforts that we're making. It's just this internal thing about the mama drama, and therefore treating everybody who stops breathing at night, how horrible that is. So I really appreciated that. I have a question on the study though. The study that you made reference to was, correct me if I'm wrong, John, was with the matrix. And so what we were really studying was, no surprise, the effectiveness of determining an ideal posture through a very sophisticated, incredibly frustrating that we've lost it, algorithm on where that bite, initial bite registration should be, and then using an appliance. But there was no control group.
Sancho never lets me get away with anything. I mean, oh God.
Who's that?
Barry. You nailed me. No, okay. It's absolutely the point. So I cheated, not in any fundamental way, but I cheated, Barry.
I love you.
I didn't tell everyone that we didn't select the patients. Everybody got the oral appliance, Barry. So we would start with 100 people with sleep apnea, and they all got an oral appliance, and then we looked at the outcomes. So we didn't select people who would or were not. We took all, let's say, all mild to moderate patients that with broad inclusion criteria. We took them all, and we gave them all an oral appliance, whether the matrix said they were a good candidate or not. We didn't know that. We were blinded to that. Gave them all an appliance, and then we looked to see whether the AHI was less than 10 or not. So that part's fair, but nonetheless, they were in that study. But probably more importantly in that study, we also knew from the matrix plus, we had an idea of what a good efficacious position would be. Yeah. Now there's the problem, and so we never understood. We've been seeing better and better results from the very first time we started doing this with a Somnomed device 10 years ago. Results have been getting better and better, Barry, and we never knew why. And all I can tell you is that it may be something about knowing where to put the mandible, where to position it to, take your bite, where to take your bite. You guys know, I'll have to tell me about that, but it may be something about what we were doing, and that we went immediately to a target without any screwing around. I don't know, Barry, but it's a very good point that this data has to be replicated, that I showed you. It's published data, but it is done in the context of a Matrix Plus. not to select favorable candidates, not that at all. But
I think that when you read this paper carefully, it's incredibly powerful for the potential use of the Matrix Plus. It's so frustrating. I can't even. I didn't speak to you for 6 months because I couldn't imagine talking to you when this thing. God bless you for all you've done there, and I can't imagine that frustration. But I have trouble using the word the issue of what precision or what appliance would use there, since there was only one appliance and there was no control group.
Well, I don't know why the efficacy is 94% for mild to moderate. I don't know. So, I meant to say that. I don't know if it's something about the appliance, whether it's something about the way the study was conducted or whatever. But it was fair and square, no bias at all. I mean, it actually works against the use of Matrix Plus when the efficacy goes up. Then you don't need it anymore to select patients. And so the last thing I wanted to see high efficacy. But it's there's the data. We've gone back and reviewed the data very carefully. It's very clean data, and that's what we found. So we have to understand whether when we repeat the study with the new device, and now without any intervention or any information from Matrix Plus, what do we get?
Very interesting. I look forward to that.
And how do we but even now, then how the hell are we going to start the treatment?
Exactly.
I mean, nobody talks about you guys don't talk about the elephant in the room anymore. There's still a big damn elephant in the room, and we just came up with some arbitrary stuff for our upcoming clinical trial of severe OSA, and just some arbitrary stuff. Start at 50% and go to 80 and 100. So and nobody knows.
No.
You guys are
using a percentage of protrusion makes zero sense.
Right.
Well, 0 sense. I mean, there's no correlation between the laxity of the joint and the potential effect on the pharynx. But God bless you for doing this, because we've all known, obviously now, through when we look at Annandam and Phillips and Sullivan, when we look at those studies, we're aware of some very good evidence suggesting that the severity based on AHI is not. We should not be eliminating oral appliances by definition of AHI severity. So
for sure,
this information, this study that you're doing, is exactly what dentistry needs, and we appreciate it.
Well, we're going to do it. It's going to be quality stuff.
John, if I can interject in here, John, I think, anyway, it's my humble thought here, that it's about the objective data that you're using. Almeida, along with Alan Lowe at that time, about perhaps 10, 12 years ago, I can't remember the exact year, they published a study where they evaluated the appliance outcome, and then they continued to calibrate it during the sleep study. And they increased the original success rate was something like 60-odd% of the patients met the criteria, whatever it was, under 10 or whatever they were using. And then by the time they were using the objective data to calibrate the appliance further, it got the success rate up to like 92%. And that was just, in one night using that information. Now, whether those numbers are definitive or not, what the difference was there was having some objective data to help calibrate that appliance further, right? So what you did with the matrix there, with this, the IA appliance, was you were using objective data. And of course, you got to end up with a better outcome than just using subjective information to.
We'll see. And that study that you're talking about, when they say that it goes way up, I don't know that they're using another night, a full night study. I think they
no, it was a one night. It was a one night thing.
Yeah, I think they look to say, oh well, it's all better now. anyway, I have problems with that study. No. I don't. What I want to say is, in truth, that I have no idea of why we got the great appliance. You may think it's because that we knew where to set the mandible. Maybe it is. Maybe it isn't. Everybody who was a failure was protruded out to maximum, though. Do understand that we never stopped short. So if you didn't have an AHI less than 10, protrude. Still not less than 10, protrude more. So we're very aggressive that in all of them. So, but it's complicated. I don't know, John, but we need more data. I'm going to have to run, guys.
Listen, thank you so much. You went till 9:12 here at East Eastern Standard Time. Really appreciate all the information and your dedication, John, and the time you spent with us tonight. So sincere thank you to you. And I'll make this recording available online and email the link to everybody that signed up originally. And for those of you that are still on, remember to answer the questions when you log off to be able to qualify for your CE points. Thank you all for
participating
on the panel as well. Thank you.
I think that you have inspired us to start a prayer group to the sleep gods. That maybe we can send Barry Glassman to Mount Sinai to come back with the tablets and lead us.
This is a possibility. This is a possibility.
If that's what it's going to take.
But but if anybody knows about it, it's Barry. So just talk to Barry, and he'll.
Yeah, I volunteer Dr. Glassman to lead us to the promised land.
Good to talk to you all.
Good night, John. Thank you so much.
Good night, John.
Good to see you all. Bye bye.